Spina bifida, spinal dysraphism by Dr. Muhammad Al-Tamimi, a consultant neurosurgeon and an assistant professor. The objectives of the lecture would be the definition of the spina bifida, the causes that lie behind it, how can it be prevented, how can it be managed, what is the social impact, and some further information. The first objective is the definition of the spina bifida. The spina bifida, which is literally means the cleft spine, is characterized by the incomplete development of the brain, the spinal cord, and or the meninges, the protective coverings around the brain and the spinal cord. The worldwide incidence is about 1 to 2 cases in every 1,000 births, with a slightly higher incidence in the Caucasian people and seen more in the children born in the late summer and early fall. In the anatomy review, we know that each vertebra has several important parts: the body, the vertebral foramen, the spinous process, and the transverse process. The body is the main weight-bearing region of the vertebra. It makes up the bulk of the bone's mass. Extending from the body are the transverse processes. They are thin columns of bone that point out to the left and to the right sides of the body. The spinous process extends from the ends of these transverse processes in a posterior direction. Between the body and the transverse processes and the spinal process is the vertebral foramen, which is a hollow space that contains the spinal cord and the meninges. How can the spina bifida be classified? There are 4 types of spina bifida: the occulta type, the closed neural tube defects, the meningocele, and the myelomeningocele. And we have both the spina bifida ventralis. The classification varies in severity depending on the location and the extent of the opening. And the spina bifida occulta, or it's called also the hidden one, it is the mildest and the most common form in which one or more vertebrae are malformed. The name occulta, which means hidden, it indicates that a layer of skin covers the malformation or the opening in the vertebra. This form of the bifida presents in 10 to 20% of the general population, and rarely it causes disability or symptoms. In the closed neural tube defects, however, which makes up the second type of the spina bifida, this form consists of diverse groups of defects, in which the spinal cord is marked by the malformation of the fat or the bone or the meninges. In most instances, there are few or no symptoms. In others, the malformations may cause incomplete paralysis with urinary and bowel dysfunctions. Usually this expresses itself later in the life, and it causes by the limitations of the movements of the spinal cord within the spinal column, and the patients often have low back pain or weakness in the legs, or expressing itself as an incontinence depending on the site of the tethering. In the third type, which is called the meningocele, a spinal fluid and meninges protrude through an abnormal vertebral opening. The malformation contains no neural element and may or may not be covered by a layer of skin. Some individuals with meningocele may have few or no symptoms, while others may express such symptoms as complete paralysis with a bladder and bowel dysfunction. In the myelomeningocele, which is the fourth type, which is the most severe and occurs when the spinal cord and the neural elements are exposed through the openings in the spine, resulting in partial or complete paralysis of the parts of the body below the spinal opening. The impairment may be so severe that the affected individual is unable to walk and may have bowel and bladder symptoms. Here the bony vertebrae is open and part of the meninges and part or all of the spinal cord is being protruded out of the spinal canal. And since the spinal cord is protruding, it's often not fully developed. The involved nerve roots as well are often not developed well, resulting in weakness and pain and paralysis. In addition to the abnormal sensation and the paralysis, other neurological complications may be associated with the spina bifida. The most common one is called the Chiari-2 malformation, which is a condition that's very common in the patients with the myelomeningocele, in which the brainstem and the cerebellum behind the brain protrude downward into the spinal canal or the neck area. This condition can lead to the compression of the spinal cord and causes a variety of symptoms, including difficulties with the feeding, swallowing, breathing control, choking, and changes in the upper limbs function in the form of stiffness and weakness. The other type of the spina bifida, which is called the anterior opening, which is much less common than the other forms of the spina bifida. Here the meningeal sac will protrude into the retroperitoneal space and impinge itself on the retroperitoneal organs such as the duodenum, any parts of the colon, the kidneys, the adrenal gland, the pancreas, aorta, or even the inferior vena cava. And we will pass now to the next objective of this lecture, which is the causes behind the spina bifida. The exact causes of the spina bifida is unknown. All the researches to the date has indicated that both genetic and environmental factors may play a role. The developmental process, however, that results in spina bifida is well studied. So, genetic, neuronal migration problems, white matter injury, cortical gray and subcortical matter injury may play a role. The spina bifida, which is a condition in which the neural tube, which is a layer of the cells that ultimately develops into the brain and the spinal cord, fails to close completely during the first few weeks of the embryonic development. The human nervous system develops from a small specialized plate of the cells along the back of an embryo. That is called the neural plate. Early in the development, the edges of the plate begin to curl up towards each other, creating the neural tube, which is a narrow sheath that closes to form the brain and the spinal cord of an embryo. As the development progresses, the top of the tube becomes the brain and the remainder becomes the spinal cord. This process is usually completed by the 28th day of the pregnancy. But if a problem occurs during this process, the result can be the brain disorders called the neural tube defects, including spina bifida. As a result, when the spine forms, the bones of the spinal column do not close completely around the underdeveloped nerves of the spinal cord. Part of the spinal cord may, however, stick out through an opening in the spine, leading to the permanent nerve damage. Because the spina bifida is caused by abnormalities of the neural tube, it is classified as a neural tube defect. What causes spina bifida and how can it be prevented? What would prevent the neural tube from closing properly? The foliate seems to play a large role in the closing of the neural tube, but it's unknown exactly how foliate works in this process. Foliate influences was discovered by the increased incidence in spina bifida seen in the Irish babies born the late summer and early fall. The lack of the leafy green vegetables caused by the mothers to have low levels of the foliate during conception. However, genetics also play a role in the development of the spina bifida. Mothers with one child with the spina bifida have an increased risk of additional children having spina bifida. Studies with the foliate-resistant mice also prove that. Valproic acid, adipakine, which is an oral medication used to treat the seizures of the convulsions and sometimes the migraine, the bipolar disorders, may play a role. The mechanism of the action is thought to increase the GABA levels within the brain. The pregnant women taking the valproic acid have an increased risk of having children with the spina bifida. So how can it be prevented? The prevention lies in two important factors. the good education, and the foliate intake increment. In the education, the neural tube begins to close at about day 22 after the conception, and that's fully closed by the day 28th of the conception. So taking precautions during that period is very important to prevent having a child with spina bifida. In the foliate intake increment, the recommended dose that the woman of the childbearing age should take about 400 micrograms of the foliate per day. The pregnant woman should take about 600 micrograms of the folates per day, however. And the woman with the previous child with the spina bifida, they should take higher micrograms of the foliate per day, reaching up to 4,000 micrograms. The foliate can decrease the risk of the spina bifida by up to 75%. What are the sources of the foliate? Vegetables, grains. Many foods are now enriched with the foliate, and most multivitamins subscribed by the gynecologist, they contain foliate. Some vitamins are specifically formulated for the women. Now, we will come to the management of the spina bifida. The treatment of the spina bifida depends on the extent of the spinal cord involvement. Spina bifida occulta usually presents with no neurological problems and discovered accidentally, and usually it requires no treatment unless the patient has a tethered cord with its complications. Meningocele usually requires the closure of the sac and the early management of the cyst. Myelomeningocele usually requires the most extensive treatment, and the treatment here is variable. How can spina bifida be managed? It depends on the lesional level and the spinal-related disability. The patient who is having a myelomeningocele above the L3 with a complete paraplegia and dermatomal para-anesthesia and bladder incontinence and the neuroambulatory problems, usually they should be treated with the closure of the defect with no claim of having any neurological recovery later on. In the L4 and below, usually, they have a clinical presentation, usually just like the L3, except with the preservation of some hip flexors and hip adductors and the knee extensors. And the patient usually is ambulatory with risks of bracing and orthopedic surgery. In the S1 and below, it's the same as for the L4 and below, except the preservation of the feet dorsiflexion and the partial preservation of the hip extensors and the knee flexors. Usually the patient is ambulatory with minimal aids. Here the surgery is not that extensive. In the S3 and below, the patient has got a normal lower extremity with motor function. However, he has got a saddled sort of the anesthesia and the variable bladder and rectal incontinence. So how can be managed? Detection is very important. Antibiotics combined with the surgeries and the careful observation and physical therapy. In the detection, usually we have to do triple screening. The maternal blood test for an alpha-fetoprotein, ultrasound for the bones defects, or amniocentesis. The alpha-fetoprotein usually is elevated in about 75 to 80% of the cases of the spina bifida, especially the myelomeningocele type. And sometimes we may insert a needle into the uterus to take an amniocentesis using the needle to collect the amniotic fluid. Antibiotics is a cornerstone in the management. In some cases, the spinal cord is exposed to the environment. Antibiotic is very important to prevent meningitis. Surgery is advocated in some cases. For example, when the spinal cord being exposed to the environment or being tethered, the surgery is performed either on an elective or an emergency situations. The surgery is performed in order to cover the spinal cord with the muscles and the skin and to untether the spinal cord. In utero, surgery has become also a variable option for some cases. Here are some pictures how we can close it. We have to expose it layer by layer, and we reconstruct it layer by layer, starting from the dura, and we have to return the cord or the nerve roots back to its space, and then we make all the subcutaneous and the cutaneous coverings. Careful observation is very important. The children in the myelomeningocele often have the hydrocephalus, which is the blockage of the CSF, and the children may present with the paralysis, blindness, mental retardation, inability to speak, convulsions. Any changes in the mental status or the behavior should be quickly brought to the attention of the children's physician. Physical therapy is also very important. The spinal cord damage can cause muscle weakness and wasting. The speech therapy with a speech therapist may also be useful for some individuals. What's the social impact of the spina bifida? The prognosis and any deficit are dependent upon the level of the involvement. It's estimated that from 5 to 40% of the world's population may have spina bifida occulta. Myelomeningocele, however, is not very common and often has a minimal impact once the cyst being removed. Myelomeningocele has the largest impact on the patients and their families. The children born with spina bifida today, they require some special treatments, multi-surgeries, starting as early as 48 hours, physical therapy, bowel and bladder surgery, and in many cases, special centers are better equipped to treat the children with spina bifida, and they have a variety of specialists on their staff. Most surgeons that are treated early will have normal IQ and being able to attend the public schools. Mobility is the biggest concern for many patients with spina bifida. With proper treatment, individuals will live well into adulthood. Thank you.